Say in the last 12 months, how many of you have had to make adjustments in how you treat your patients because of a BCG shortage? Yeah, pretty much everybody. Yeah, no one is spared from this. So these are my disclosures, and I've underlined the ones that are relevant, both from a clinical trial and support and consulting advising. So this is what I'll cover. And I'm not going to get too much into the cystectomy question because Dr. Godoy will be talking about in his talk. So where this got started, if you're old enough, like me, you remember having two strains of BCG. Connaught, which was made by Sanofi Pasteur in Canada. And there's some data to suggest that maybe Connaught was a better strain of BCG because of just some how it induces an immune response. But the company went offline with their production in 2012, and then a couple of years later were permanently out of business. And then, as you all know, I think Merck also experienced at least one or two production problems, and they were offline temporarily, creating just a disaster for our patients. So Merck manufactures Tice BCG in 70 countries. They're the sole supplier for 70 countries. And they have one manufacturing plant in North Carolina. They doubled their production a couple of years ago. Merck is not the villain here. They're actually kind of saving the field for the moment. There's obviously other strains of BCG that are available in other parts of the world, but this is what we have to do. And the way they've managed the supply issue is on an allocation basis, and it's essentially was based upon your hospital, your clinic, or your office use of BCG leading up to that. All of the stakeholders in this are any organization that represents patients, and obviously our professional societies, the AUA, SUO, developed this joint statement. I was a participant in developing that. And essentially what it's saying is the following. A patient with low-risk disease, so TA low-grade, first occurrence, should never be treated with BCG. Quite frankly, the only thing that they should get is a perioperative single dose of chemotherapy. Intermediate risk is like well-suited for treatment with intravesical chemotherapy. And quite frankly, for the last 20 years, I've never used BCG in that setting, though I know that, and I'm not faulting this because it's been in our guidelines, that's been appropriate. And it'd be BCG induction plus 1 year of maintenance, but my request is don't do that for low-grade disease. And then hold your BCG for patients with high-risk disease. So the easy way to remember that is anybody with high-grade TA-T1 or TIS. Now the AUA says that a solitary TA high-grade tumor that's 3 centimeters or less is an intermediate risk. Okay, you can treat that with intravesical chemotherapy. And if you have adequate supply, the standard of care would be induction plus 3 years of maintenance, and we understand fully that probably the majority of patients don't get out to 3 years, either because of recurrence or toxicity, but you can also dose reduce to manage your supply. And then if you don't have any BCG, then I'll talk about intravesical chemotherapy combinations. So Merck put out a statement in early 2021 that they're building a new plant that takes 5 to 6 years. So kudos to them for supporting the community, but that's not going to solve the problem for a while. And from a clinical trial development standpoint, I'll show you, this creates an enormous opportunity for drug development in the BCG naive space. So remember that you can, not so much for induction, it takes about 4, you see peak cytokine induction around cycle 4 or 5, but with maintenance that peaks around 2 or 3, and you can get that same level of immune response with a lower dose of BCG. So it's relatively easy to manage that, and you have to pay very close attention to toxicities so that you're not beating the patient up, or and we've all seen these bad bladders after BCG. So I think it allows us to take a bit more of a sophisticated approach and an individual patient approach. So I have to be very careful here about splitting doses and, say, taking a vial of BCG and treating 2 or 3 patients in the same day. So there's a J code for that, which is great, but CMS, to my knowledge, has not said that that's okay. So I'm going to show you a slide from Chad Rich, who's in Florida University. I think Chad's at the University of Miami. They're doing that. I think they might be doing that at MD Anderson, and I'm not trying to, turn anybody in, but you have to be very careful to see if that's allowed by the payer in your particular community. Next slide. So I just threw this up because this is sort of my simple way of how to figure out how to treat patients. This is the EAU risk stratification. I've used it forever. I think I already mentioned that earlier. So one of the things to remember is that there's really only one maintenance schedule that's been shown to be effective in reducing recurrence and progression over the long term. And that was a study that was led by Don Lamb, SWOG 8507. It's been out in the literature for 20 years, and I hope that's what we're all doing. It's in the guidelines. And what you see on the right is with and without maintenance, papillary versus CIS. And there's very clear and obvious differences. What you see on the left is with different schedules, it's ineffective. So, once a month, which I've, quite frankly, I don't see much of that anymore. It doesn't work. And so we should be using the SWOG regimen. This is a trial that was done in the EORTC, and what they did is they took intermediate risk patients and high risk patients, and they treated them differently. And they tested reduced dose BCG and shorter maintenance schedules. And I've interpreted the study to show affirmation, though others have looked at it slightly differently, of the 3 years of maintenance for high risk disease is still the standard of care. So this I borrowed from Chad Rich, and he's doing this. And obviously they've gone through all the things that they need to do internally to verify that they can bill for this. The billing is the tricky part. But from a resource utilization, it's perfect, right? Because you can take your vial of BCG and spread it amongst different patients. Now, I will tell you that I do not advocate dose reducing during induction, unless you're managing that for toxicity, though others have. And then if you're stuck in a situation where your choice is, well, I really need to start maintenance therapy, but I don't have enough BCG, but if I split dose or reduce dose, I can manage that. That's fine. Ideally, if you can get a patient through induction plus 3 months, 6 months, you've actually gone, you haven't gone all the way, but you get a really good bang for your buck just with that. And so if that kind of helps sort of manage that supply when it's low. Next slide, please. So here's a typical intermediate risk patient. So remember, intermediate risk generally is TA low grade, multifocal, and or recurrent. Next slide. And this is one I want you to memorize. So this was a trial we participated in. Jessie Au, pharmacologist at Ohio State. She's now been out in San Diego for a long time. She developed a computer model based upon her research that would put a constellation of things together that would optimize the delivery of mitomycin C to both the mucosa and the submucosa of the bladder. If you double the dose, double the concentration, so instead of 20 and 20, it's 40 and 20. Dehydrate the patient overnight so they're not producing urine and diluting the drug during the treatment. Alkalinize the urine in an alkaline pH that optimizes delivery of the mitomycin C. And then, interestingly, do a scan PVR to make sure that even though you think the bladder's drained, check it again, because when we did the trial, we found that, oh wow, when you do the ultrasound, a lot of patients still have a lot in their bladder, and of course that's going to dilute the drug. And what you see, the optimized regimen essentially doubled the recurrence-free survival at 5 years. So this is what we've been doing, quite frankly, for 2 decades. It's supported by level 1 evidence, and it works really well for low-grade disease. Next slide. These are just the guidelines, and you realize that the guidelines still have BCG in there, and I wouldn't fault it, if that's fine for high-grade disease, but this is, and I think the guidelines are fairly consistent in recommending intravesical chemotherapy. Next slide, please. So high risk. So we all know what high risk looks like. This is a patient with a high-grade T1 tumor. Standard of care is re-resection. Don't pass go without doing that, even if you think you got it all. The data show that even in expert hands, a lot of times there's residual disease, and it also gives you a chance to biopsy the rest of the bladder to look for CIS. If you have enhanced cystoscopy measures, that also comes into play. So she had a negative re-resection. Next slide. So these would be the choices for treatment. I think everybody can figure this out in advance. Go ahead, click it. But in a BCG shortage era, next, this would be an option for you. And I'm going to show you some data, and our current favorite, and I think the community's favorite, is gemcitabine docetaxel. Next slide. So these two slides, I went through in clinicaltrials.gov and asked the question about trials in the BCG naive state. So these would be the typical patient who you'd start on full dose induction BCG, and you can see that some of these are big trials. A couple of folks are looking at combining a PD-1 inhibitor plus BCG, and the control arm, of course, is BCG. There's this nanodosi is a clever injectable form of microdocetaxel. Docetaxel is a very active drug in this disease. Next slide. The fourth one down, sasanlimab, is an oral PD-1 inhibitor. Makes a lot of kind of interesting sense. No, go back. And then just for full disclosure, the Verity is a company in Canada who's trying to bring the Russian strain into the US. And this is a proposed trial that's on clinicaltrials.gov. And I'm doing some consulting for them and working with them at the FDA to try to get this and a couple of other things approved. Next slide. So this is a trial that we're doing in the Southwest Oncology Group, big 959 patient trial. We designed this quite a long time ago. We actually were trying to, it's with, the control arm is Tice. We spent a couple of years negotiating with Sanofi Pasteur until we finally said, see ya. And that was actually a smart decision in retrospect in terms of what happened. But this is a randomization of Tice versus Tokyo BCG with or without priming. The idea is immunize the patient with BCG just like you would for TB, prime the immune system so when they see the BCG, they rev up that immune response a lot faster, and we're looking at a 1-year time to high-grade recurrence endpoint. Rob Svatek at San Antonio is the PI. Next one, we've completed accrual to this, and we're actually working with the FDA to see if they'll, they actually reached out because they're very interested in the data in CIS patients. And I'm not here to tell you that Tokyo is going to be in the market anytime soon. It may never get into the market, but I guess we're working with that. This is really interesting. So BCG failure would technically define a patient who had induction only and recurs, and at least in this randomized trial, albeit it was published over a decade ago, showed that intravesical gemcitabine was superior to BCG. The problem is we don't really have any level 1 evidence to guide us in that setting. So you could give more BCG certainly, or you can switch to, if you were going to switch, I'd say, and it's a high-risk patient, I'd do the doublet therapy. Next slide. And I think that's what, yeah. So this is the combination, gemdosi. And you might be sitting out there going, golly, I mean, 3 hours, 2 drugs, this doesn't sound like high throughput. I get it. I understand it. This is actually really easy to do. We and a lot of places. Anybody doing gemdosi? Raise your hand. Yeah, so I would really encourage you to think about this. It is a little bit more time intensive, but as you can see from the curves, it works. And it can really help our patients when they have recurred after BCG, or if we don't have any BCG, and it's a great alternative. Next slide. Just click through. And Dr. Godoy is going to go into this in a lot of detail. And this is simply identifying the very high-risk patient for whom they probably ought to have a cystectomy up front and not mess around with intravesical therapy. Next slide. And this is why, if you look at the curve on the right, when you do a cystectomy before a patient develops muscle-invasive bladder cancer, remember there's an understaging error, probably that's at least 20% with patients with large volume high-grade T1. You see the substantial drop-off in overall survival. And so I think too often, and I've certainly made this mistake myself, we hold cystectomy until we've sort of missed that window of opportunity for cure. And so Dr. Godoy will give you sort of the guidelines to avoid that. Next slide. So this is just a summary. Many of you know that I'm quite fond of this last bullet point. There is no treatment that we have that has a 100% durable complete response rate. So cystectomy really works. I understand the toxicities, I understand the morbidity, mortality risk, and believe me, I get it. But it's very effective when it's used, and I'll go ahead and invite Dr. Godoy to come up, and he's going to go into this in a lot more detail. Thank you so much, and again, thank you all for being here.